Hello viewers, as per the maximum request that I received, my next case discussion will be on the C-shaped canal. So clinical tips and tricks to manage your C better. Now first we have to know that what is a C-shaped canal. Now there is a confusion that some people thought that C-shaped canal means it will look like C in the radiograph, or C-shaped canal means the tooth will look like C shape. Both are wrong. It will not look in a radiograph like a C shape. It will not look clinically preoperatively like a C shape, because clinically if you see the tooth that having a C shaped canal, it has normal curves, normal grooves, normal other anatomical features, no such exception. So what is C shaped canal? Now C shaped canal means it is the root canal system that will look like a alphabetical letter C in a cross section. That means if you do a access cavity and if you see the floor of the pulp chamber, you will follow the and you will if you follow the grooves, you will see like a alphabetical letter C shape in the floor of the pulp chamber where the root canal system begins. That means on the left side picture, it is a example of a C-shaped canal. After the access opening, here you can see that this is the orifice, this is the orifice, and the grooves are connecting to orifices is completely looking like a alphabetical letter C here. Now in the second case, yes, it is also a case of a C-shaped canal. It will look like a C when you do a access opening of this tube, like this. So C-shaped canal means in a cross section of the root canal system, it will look like a alphabetical letter C. Now, why always C? Now, why we know about the C-shaped canal so much? Because in recent times in your clinic, you can expect that every 100 cases of your mandibular second molar, of root canal cases of your mandibular second molar, 17 cases you can expect that will have a C-shaped canal. So it is important to know about the C-shaped canal, because as per some studies, in vivo studies and systematic review in Indian population, the most commonly encountered C-shaped canal is mandibular second molar, that is about 17.3 percentage, followed by mandibular first premolar and mandibular third molar, both having 8.4 percentages, and followed by the maxillary second molar, that is about 4.8 percentage. Now all those references I will give in my the link I will give in my description. If you want to know more about it, you can check in my description. Now this is the first case. Now if you see the radiograph, so let's analyze the radiograph. Now start from occlusally. There is a filling is present on the occlusal surface of the tooth, and this is the tooth number 47, that is a right lower second molar. Now this is a caries present on the distal aspect of the tooth. Here you can see, yes, and this caries involves the distal pulpon. Here there is a root canal system present on the distal root. Yes, it is a single wide root canal that is going from the orifice up to the middle third. I can appreciate the root canal, and in the apical third it is not quite visible. And in the mesial pulpon, this is the mesial pulpon, and the root canal is very thin and it is not very well appreciated, but I can see that starts from the coronal third and to some extent the middle third. Up to this point I can see this root canal, and followed by it is not appreciating I can appreciate it well in the apical third of the mesial root of this root canal system. So the patient having a symptom of pain on chewing on that right side of tooth and food lodgement. Now This is the working length of the tooth. Now, if you see, this is a pre-endodontic buildup with the help of composite. This is the pre-endodontic buildup here. Now, this is the distal canal, the large distal canal here. This is the mesio-buccal canal that merges with the distal canal at the apical third here. You can see this is the mesio buccal canal that merges with the distal canal in the apical third. Now this small file is a 10K file that represents the mesiolingual canal that merges with the mesiobuccal canal at the junction of the middle and apical third of the root. So if you see this working length radiograph, it is quite similar to this of to that of this right side picture. That one canal here, mainly the distal canal, will start from the orifice, ends towards the radiographic apex individually. Another canal will start from the orifice and it will continue its own course and meet with the first canal in the apical third of the root. So this is the mesial canal and this is the distal canal. Same like the radiograph, this is the distal file through the distal canal and this is the mesiobuccal file which meets in the apical third. So this is a case of a type A classification according to the Fan et al. In 2004. It is a type of a radiographic classification. Now this is the picture on the left side, which is a master cone picture. This is a 36 GP I have placed in the distal canal, and in the mesiobuccal I place a 34 here. This is a 34, and this is a 25 4%, which merges the mesiobuccal canal here. 1 GP, 2 GP, 3 GP. Now on the right side, this is a picture of the access cavity of this tooth. Now if you see that this is the distal area, here it is the distal, this one is the mesial, this one is the lingual, and this one is the buccal. Now here I made a composite from here to here. This box is a pre-endodontic buildup done with the help of composite, and this is the large distal canal here. This is the mesiolingual canal, small in diameter here, and this is the mesiobuccal canal. Now one important thing in this picture is, while you are doing a root canal treatment in a C-shaped canal, please don't do a conventional cavity like you will do in normal molars, in lower molars. Ideal shape of a cavity in case of your normal molar is rectangular or trapezoidal. If it is a 4 canal system, 2 canal in the mesial, 2 canal in the distal. But in case of C-shaped canal, the access cavity will be small. It is not that large than that of your traditional access cavity. So while you are starting your C-shaped canal, the access cavity, while you're starting the access cavity of the C-shaped canal, you place the bar centrally, you take the drop, check the deroofing with the help of your DG16, and remove as minimum as possible just to complete the deroofing properly. Now if you know that it is a C-shaped canal, then only this kind of access cavity you will do. Otherwise, if you have a mind that I have to do a normal traditional shape of the access cavity, so you will start from here, it will go from there, and this will go from this to there, that, and this will come from this to that. Now it will remove maximum amount of tooth structure. So the additional removal of the tooth structure may compromise the long-term survivability of the tooth. So remember one thing, that C-shaped canal, the access cavity will be smaller than that of your traditional access cavity in your lower molar. Now this is a obturation picture of this tooth. On the left side, it is taken, the radiograph is taken after the down pack. Here, the distal, the mesolingual, the mesiobuccal, only 4 to 5 millimeter apical gutta is retained here. And this is on the right side, it's a picture after the backfill. Note how beautiful it looks after the warm vertical compaction. This is the distal, this is the mesolingual, and this is the mesobuccal. Now this is the follow-up picture of this 4-7. Approximately after 1 year, the patient again came to my clinic with the problem of this 6. So on that time I've taken a picture of this 7 and it's completely normal. Patient has no problem, no symptoms, no periapical abnormality. It's quite fine. Now the second case. Now this is the tooth number 3-7, that is left lower 7. Now this is the preoperative radiograph. From the radiograph you can see that this tooth is already a access cavity done previously, as because as per the patient conversation, the patient is already gone for the treatment of 7 with some other with to some other dentist, and the dentist will do a root canal on this, try to start the root canal on this tooth. And after the first or second sitting, the patient said that the pain is not going, the pain is still there on that time. So the patient come to me for a second opinion about the tooth. So because he want to save the tooth, and this is a preoperative picture. Here is a access cavity of the tooth, little bit more removal of the dentin here, and this is the root canal system. It is a quite large root canal. If you see, it is that is the center of the tooth, and this is the root canal. It going like this, and in the middle third it can appreciable, and after that it is going to the apical third, but it become narrow in the apical third. No other shadow of root canal except of this. Here, this is the, sorry, this is the root canal. This is the main root canal. I can see from this radiograph. No other accessory canals or any other canals, other main canals are visible in this radiograph. Now this is the picture of the access cavity. This is the picture of the access cavity of this 3-7 after removal of the caries. Note the size of the orifice. It's a huge size of the orifice after tooth number 3-7. Now it is classified under the C4 category of C-shaped canal, that is a single large canal is present at the center. Now on the left side radiograph, you will see that there is a down pack. Apical 3 to 4 millimeter gutta is here only, and on the right side picture I did a backfill of the radiograph. In the radiograph you can see that. Now you will see that how beautiful it will look after the down pack and the backfill, and this is the picture after the obturation. Now this is the follow-up picture of that tooth of 3-7, and the patient has no problem with the tooth have a normal form and function, and no such periapical abnormality and no such other problem, clinically and radiographically detectable. So the patient is happy. Now this is a third case. It is a Different case, it is not a lower 7, it is a lower 8 case, that is a lower third molar case. Now if you see the preoperative radiograph of this third case, this is the 7 and this is the 8. The patient had a pain on this 8, and if you analyze the x-ray, there is a caries present on the mesial surface of the tooth that coincide with the mesial pulp horn, and this is the pulp chamber, is quite visible, sufficiently visible here. And if you see the root canal from the top, that is from the orifice to the bottom, it is quite visible, and it goes from the top to the bottom individually in a single course. And this is the distal root canal, starts from here and it will go like this, individual root canal on the distal root. Note here also, and before the two cases also, all those tooth have a fused root or a conical root. This is the thing. Now note the radiolucency present here. Now the extension, for the extension you have to see the right side radiograph here, the proper extension, you will see the radiolucency. Not only this tooth, but also the previous two cases which I have shown to you also have a conical root or a fused root. So it is a radiographical, as per the radiographical classification, it is categorized under type B, where both the canal, that is the distal canal and that is the mesial canal, they will start from their orifice and end to their radiographic apex individually. Now this is the picture of the access cavity of that tooth, that is 3-8, that is the third molar. Now here, this is the buccal side, this is the lingual, this is the mesial, and this is the distal. So if you will see that, if you follow the groove, this is a large orifice present on the distal, and this is a orifice that is present on the mesial and buccal, that is mesiobuccally. The orifice is present. So this is looking like a C. If you see this, if you compare this my case with the classification system, it will look like this. It will look like this. It is categorized under C3 type of canal configuration of C-shaped canal. Now this is the picture of the obturation on the left side. With the this obturation is a single cone obturation with the along with the bioceramic sealer. I have taken two appointments. First appointment I give some intracanal dressing, and next appointment after 10 days I obturate the canal, as the patient had no symptoms and the canals are dry. So I obturate the canal. Here some amount of extrusion of the sealer you can appreciate here also and here also. And this is on the right side, is 1 month after the obturation. If you compare these two on the left side and on the right side, you will see that the radiolucency already present here on the day of obturation, and here on the day after 1 month of the obturation, it already starts healing. The radio density is decreased. Now this is the follow-up picture of this tooth. If you see the follow-up, the radiolucency, the periapical lesion is completely gone, and the bone formation is absolutely normal, like the normal teeth, and patient had no symptoms, and the tooth is in normal form and function, and no such abnormality is there. So in follow-up, the patient is happy, and I am also very happy to see that the healing is proper. Now there are three rules I must say that you have to remember before you open the C-shaped canal for a root canal treatment. The first is pre-operative judgment. Now pre-operative judgment is done by means of two things. First is the location. Most commonly the C-shaped canal is located in lower 7, and the second thing is that the shape of the root, mostly it is in conical in shape, or the roots are fused with each other. So remember these two things: fused root, lower 7, most commonly associated with C-shaped canal. That is number 1. Number 2, no traditional axis. Because if you will do a traditional rectangular shaped axis or a trapezoidal shaped axis, it will cause you more destruction to the tooth structure. Ideally, in case of C-shaped canal, the access cavity size should be small than that of your traditional access cavity in lower molar. Now, rule number 3, proper irrigation and obturation. Now, irrigation is the prime importance on every root canal along with the C-shaped canals, because these C-shaped canals contain more amount of fins and webs, which are the thin channels connecting the main canal, and these thin channels contain lot of amount of bacteria and pulpal tissue. So proper dissolve this bacteria and the pulpal tissue, you need to do a proper irrigation by means of sodium hypochlorite at a high concentration with a sufficient time and along with activation, and try to do a obturation with warm vertical compaction because it will give a better sealing ability than that of your cold lateral compaction or a single cone obturation. But in case if it is not possible, and you have only the option of single cone obturation, then try to use a sealer that have a obturating property and low film thickness like gutta flow, that is silicon based sealer. And because they have contained this molten or smashed gutta percha in the sealer, so they will help to improve the sealability of your tooth if you use a single cone obturation. And except of this, you can use bioceramic sealer as well, because over the period of time they took the moisture from the canal and get mineralized along the interface of the gutta percha and the root canal wall, so they will also give you a better sealing ability. So remember these three rules before opening a C-shaped canal for a root canal treatment. So if you found this video is useful for you, please don't forget to like, share and subscribe my channel. And if you have any comments or any doubts or any query, please mention in the comment section. We will meet in the next video very soon. Thank you for watching.